All right, welcome to The Explainer. Today, we're building a real-world clinical guide for managing HIV in India. Now, this isn't just theory, okay? This is for you, our future doctors. We're going to give you a solid roadmap to handle one of the most important public health challenges you'll face.
Okay, so here's how we're going to break this down. First, we'll look at the big picture in India. Then, we'll dive into the virus itself, how it attacks the body. After that, it's all about you in the clinic, what you'll see, what you'll do. And we'll wrap up with how we're fighting this on a national level. Sound good? Let's jump in.
So, first things first, before we can treat the patient, we've got to understand the world they're living in. Let's get a handle on the sheer scale of the HIV epidemic right here in India. So, look at that number, 23.1 lakh. That's, over 2 million people. And, it's so easy to just see a statistic, but every single one of those is a person, a family, a story. And you're going to be on the front lines. Your skills are absolutely critical if we're going to win this fight. Now, what's really important to get is that the epidemic isn't spread out evenly, not at all. It's heavily concentrated in certain key groups. So for you, as a clinician, what does this mean? It means you have to be super aware and proactive when it comes to screening and talking to these populations. And this is huge, you've got to do it without an ounce of judgment. Creating that safe space is half the battle. All right, so we've seen the national picture. Now let's zoom way in, from the population right down to the person, and see what this virus is actually doing inside the body. Okay, so what is HIV? Well, at its core, it's a retrovirus with a really nasty trick up its sleeve. It goes after the very cells that are supposed to protect us, our CD4-positive T lymphocytes. Think of these CD4 cells as the generals of your immune army. HIV doesn't just fight the army, it takes out the leadership. And once the generals are gone, the whole defense system just crumbles. This timeline, it really shows you just how sneaky this virus is. So right after infection, you might get some flu-like symptoms. Easy to miss, right? Then silence. For years, sometimes a decade, the person can feel totally fine. But under the surface, the virus is just chipping away day after day, destroying that CD4 count. And then bam, the count drops below 200 and you've got AIDS. Our entire job with today's medicine is to stop this timeline dead in its tracks. So, as that immune system gets weaker and weaker, the body basically becomes an open door for germs that a healthy person would just brush off. We call these opportunistic infections, or OIs. And honestly, learning to recognize these is one of the most critical skills you'll develop. Okay, so let's talk about one of the classics. You are going to see this a lot. Oropharyngeal candidiasis, or, thrush. It's often one of the very first things you'll see that screams, hey, this person's immune system is struggling. So you're looking for these white patches in the mouth, on the throat. It's a huge clinical clue. And check this out. It can get way more serious than just in the mouth. What you're seeing here is an endoscopic view. That white stuff is the candida, and it is spread all the way down into the esophagus. Now you can imagine how painful that is to swallow. This is a big deal. It tells you the immunosuppression is pretty advanced, and you need to act fast. And here's the thing. It's kinda a vicious cycle with other STIs. Infections that cause ulcers or sores, they make it way easier for HIV to get in and also easier to pass it on. Plus, if someone already has HIV, these other STIs can be a lot worse or look, different. So you've always got to have a high index of suspicion. And speaking of which, look at these two. These are classic genital ulcers you absolutely have to be able to tell apart. On the left, that's a primary syphilis chancre. On the right, genital herpes. Now, what's the number one question you ask? Does it hurt? Syphilis is typically painless. Herpes is painful. Just remembering that one thing can really help guide your diagnosis. Okay, so your patient comes in, you've seen the signs, you're suspicious. What's next? This is your part, the clinical response. Let's get into diagnosis and lifelong management. You really just need to remember this diagnostic triad. It's your bread and butter for HIV care. First, the HIV test itself. That's your simple yes or no. Second, the CD4 count. That tells you, okay, how much damage has been done to the immune system. And third, the viral load. This one tells you how much virus is in the blood and, crucially, if your treatment is working. You'll be ordering these three all the time. So how do we treat it? Well, the guiding principle today is super clear and aggressive. Test and treat. What that means is the moment someone tests positive, we get them on antiretroviral therapy, or ART. And it's not just one drug. It's always a combination, usually at least 3, to attack the virus from different angles. And what's the goal? Simple: to smash that viral load down until it's undetectable. For life.
But look, your job doesn't end when you write the prescription. Not even close. You have to become a bit of a detective, always on the lookout for side effects. For example, if your patient is on efavirenz, you need to be asking about their dreams, their mood. If they're on tenofovir, you're keeping a close eye on their kidney function. Dolutegravir, you ask about sleep. Being proactive about this stuff makes all the difference. And now for maybe the single most important thing you will ever tell your patient. This right here. Over 95% adherence. These drugs are incredible, but they only work if you take them every single day. If you miss doses, you give the virus a chance to fight back, to mutate, to become resistant. And you have to explain this, but with empathy. This is a partnership. Adherence is a team sport. Okay, let's zoom back out. Because everything you do in the clinic, every single patient you diagnose and treat, it's all part of a much bigger national strategy. It's about how we as a country are going to end this epidemic. And a huge part of that strategy is prevention. You need to know the difference between these two, PrEP and PEP. Think of PrEP, or pre-exposure prophylaxis, as a daily shield. It's for people at high risk to prevent getting HIV in the first place. Then you have PEP, post-exposure prophylaxis. That's the emergency button. You take it after a possible exposure to stop the virus from taking hold. So PrEP is the plan, PEP is the emergency. So, what's the grand plan for India? It all comes down to this, the global 95-95-95 targets. This is our North Star. It's an ambitious goal for sure, but it's the official roadmap to ending AIDS as a public health threat.
So what does 95-95-95 actually mean? It's a cascade. First, 95% of all people living with HIV know their status, so we have to diagnose them. Second, 95% of those people are on ART. We have to get them on treatment. And third, 95% of those people on treatment are virally suppressed. And that last part is the magic bullet, because if someone is virally suppressed, they cannot transmit the virus to their partners. Undetectable equals untransmittable. That's how you break the chain of transmission.
So let's end with this question for you. As India pushes to meet these goals by 2030, what's your role going to be? Are you going to be the clinician who gets that early diagnosis, the one who masters long-term compassionate care, or maybe the advocate who fights stigma and champions prevention? Really think about it, because the final push to end this epidemic, well, that's on your generation.